Good afternoon, guys. Let me scoot back so everybody can see me, and then we'll start the presentation B for y'all. Good afternoon, folks. Today's B discussion is about homebound seniors living alone, often falling through the cracks of the U.S. healthcare system. So here we go with today's B discussion. Please join me in this afternoon's discussion B. The article highlights how homebound seniors living alone often fall through the cracks of the U.S. healthcare system. Here are the main points. Underserved population. Roughly 2 million older adults are completely or mostly homebound, with an additional 5.5 million requiring significant help to leave home. These numbers far surpass the 1.2 million living in nursing homes, yet they receive considerably less attention and supports. Example cases. Okay, I'm going to give you one example, guys. Carolyn Dickerson, a 76-year-old lung cancer survivor with multiple chronic conditions, lives alone in central Harlem. Her frailty and isolation, combined with limited access to care, illustrate the danger faced by many in similar situations. Okay, lack of infrastructure. Despite the scale of the issue, there's inadequate focus from policymakers, researchers, and healthcare systems on this vulnerable group of people, leading to gaps in services and resources for aging in place. Safety. If you'd like, we can explore how models like self-directed care or programs such as Mount Sinai visiting doctors might help address these gaps. Neglecting homebound seniors who live alone carries significant implications, not just for individuals' well-being, but for public healthcare systems and broader social equality. Increased health risk, isolation, and limited access to care heighten the risk of untreated chronic conditions, mental health decline, malnutrition, and falls. This can lead to avoidable hospital. This can lead to avoidable hospitalizations and premature institutionalization. Hold on. Give me 1 second, folks. I'll be right with you. Straighten up my notes. Okay, rising healthcare costs. When basic needs aren't met proactively through home or community-based care, crises become inevitable, often leading to costly emergency interventions that could have been prevented. Moral and ethical concerns. Ignoring this population raises serious questions about ageism, social economic disparity, disparity, and social responsibility. It exposes gaps in a system that prioritizes visibility and mobility over quality, equality, and need. strain on informal caregivers. When systems don't support seniors inadequately, the burden often shifts to family members, amplifying caregiver burnout and creating ripple effects across generations. Lost opportunities for innovation. By overlooking this growing demographic, we miss the chance to pilot models like self-directed services, community paramedicine, or AI-enabled remote monitoring tools that could make aging in place both safer and more dignified. Would you be interested in exploring scalable interventions or policy recommendations tailored to this group? You you might find that a few adjustments could have systematic impact supporting homebound seniors. Especially those living alone, requires a blend of clinical care, social support, and policy level innovation. Here are some of the most effective interventions. One, home based primary and palliative care. Programs like Mount Sinai's visiting doctors deliver comprehensive care directly to patients' homes, addressing chronic conditions, medication management, and end of life planning. Studies show that these models reduce ER visits, hospitalizations, while improving quality of life. Self directed services, or SDS, allows individuals to hire, train, and manage their own caregivers, often a friend or family member, which boosts autonomy and community con, continue continuity of care. Continuity, continuity of care, especially effective when paired with counseling and navigation support to ease the administrative burden. And then you have 3, which is telehealth and remote monitoring, virtual visits, and remote sensors enable regular check-ins without requiring transportation. AI enabled tools can track vital signs, detect falls, or signal behavior changes, helping to intervene early. Community health workers and mobile clinics. These bridges between the healthcare system and isolated individuals can offer culturally appropriate, consistent care, especially in underserved areas. Mobile units also bring preventative care, vaccines, screenings, and even dental services directly to doorsteps. 5. Social prescribing and loneliness interventions, connecting individuals to community programs, phone companionship networks, or virtual support groups can combat isolation and improve mental health. Programs like Meals on Wheels don't just feed people, they serve as crucial wellness checks. Policy innovations. States could expand Medicaid waivers to support home modifications, transportation, or mental health services, funding long-term care ombudsman programs and caregiver stipends would also strengthen the safety net. If you'd like, I can map out how these could be adapted to Pennsylvania landscape or dig deeper into models like capable or PACE that integrate medical and functional support, supporting homebound seniors, especially those living alone, has profound policy implications that ripple across healthcare, economic stability, and social equality. Here is a breakdown: refining long-term care priorities, investing in home and community-based services shifts the focus away from Institutional care. This demands real relocation of Medicaid and Medicare funds to support in-home medical care, personal assistance, and environmental adaptations like stair lifts or grab bars. 2. Strengthening the direct care workforce. Policies would need to expand recruitment, fair wages, and training for home health aides and personal care attendants. This not only improves quality of care but creates sustainable jobs in an aging economy. 3. Expanding self-directed models. Formalizing models like agency with choice empowers seniors and their families to personalize care. States may need to amend waiver structures and offer clearer guidance to reduce bureaucratic hard hurdles. Give me a minute. For incentives, innovation, reimbursement policies can encourage the use of telehealth, remote monitoring, and community paramedicine technologies that extend reach while maintaining patient dignity and independence. 5. Addressing health equality. Supporting this group would tackle systematic neglect of individuals who are isolated, low income, and often people of color. Policy reform becomes a level for civil rights and inclusion, aligning with broader public health goals. 6. Integrating social supports. Cross-sector collaborations with housing, nutrition, and transportation services require policy mechanisms that can transcend traditional healthcare silos that could mean bundled funding models or streamlined eligibility processes. Would you like to explore what Pennsylvania is doing in this space, or what changes might accelerate reform at the state or federal level? Current discrepancies in senior care are shaped by a mix of social, economic, geographic, and racial and systematic factors. Here is a breakdown. 1. Race and ethnicity. Older adults from Black, Hispanic, and Native communities often face lower access to preventative care, higher rates of chronic illness, and reduced quality of life or quality of end of life care. Language barriers and historical mistrust in medicine or medical institutions further widen these gaps. Social economic status. Low income seniors are less likely to afford prescription medications, home modifications, or out of pocket home health services. They're also more likely to be homebound and live under resourced neighborhoods with limited access to specialist or even primary care. 3. Rural versus urban divide. Seniors in rural areas may face long travel distances, fewer providers, and gaps in broadband access, making telehealth less feasible. This widens discrepancies in early diagnosis, care, community, and emergency response for disability and functional limitations. Many with mobility or cognitive changes or challenges don't receive adequate help with activities of daily living or ADLs, especially if they lack informal caregivers. Waiting lists for Medicaid, home and community-based services, or HCBS, can be years long in some states. Okay, LGBTQ older adults face increased risk of social isolation and may be less likely to seek care due to fear of discrimination. Long-term care facilities may not always be culturally competent or welcoming for folks. Data blind spots. Many homebound or socially isolated seniors are invisible in national health data, meaning their needs aren't captured in policy planning or funding allocations. Would you like to see how these discrepancies play out in Pennsylvania or explore policy models that are working to close these gaps. Several policy models across the U.S. have made meaningful strides in addressing discrepancies in senior care, especially for house or homebound, low income, or marginalized older adults. Here are some of the most promising. Number one, PACE program of all-inclusive care for the elderly. Provides comprehensive medical and social services to seniors who qualify for nursing home care but prefer to remain at home. It integrates Medicare and Medicaid funding to cover everything from physician visits to transportation and meals. Demonstrated reductions in hospitalization, ER visits, and caregiver strain. Capable is a community aging in place, advancing better living for elders. Focuses on functional improvement through home modifications, nursing visits, and occupational therapy. Evidence-based and cost savings, improve mobility, reduces disability, and helps prevent falls, particularly in underserved populations. 3. Self-directed Medicaid services, e.g., agency with choice, allows individuals to hire and direct their own caregivers, often family or friends, promotes culturally competent care, autonomy, and community, key for rural, minority, and logistical diverse seniors. California's CALAM reform aligns medical and social services through community supports like housing, navigation, food access, and in-home asthma remediation. Prioritizes equality for those with complex needs, including dual eligibility seniors and those experiencing homelessness. Okay, then we're going to go into New York's community health worker incentive initiatives. Okay, New York's community health worker initiatives embeds trained workers from the community into senior care teams to bridge cultural gaps, assist with care coordination, and build trust, especially impactful diverse urban areas and immigrant communities. Okay, 6, Minnesota. Minnesota's Return to Community initiative helps private pay nursing home residents transition back to community-based care. Okay, last page, guys. Focuses on person-centered planning and reduces unnecessary institutionalization. Each model offers lessons in scalability, uh, equity, and cross-sector collaboration. Would you like help comparing these by cost effectiveness or adaptability for Pennsylvania's policy landscape? Okay, so those are shows for today. I will see everybody Monday for shows. Until then, Gator Wellness, take care, folks. Have a good afternoon.